I like Ophir. My name is Thing, and I'm the chair of the Computer Science Department. The Computer Science Faculty Spotlight Lecture is a new tradition in our department. It is an opportunity for one of our faculty to share some recent research within the Georgetown community. This semester's Spotlight Lecture features Professor Ophir Frieder. Ophir Frieder visited Georgetown as the Royden Davis Chair in Interdisciplinary Studies in 2008. I was wondering what year that was, but it was 2008. And he decided that he liked us enough to join us as a full-time faculty member in 2010. He was our department chair and the inaugural McDevitt Chair in our department. 2 years later, he joint appointed with the Department of Biostats, Bioinformatics, and Biomathematics. He's also directs the S2ERC and Cyber Smart Center. Professor Frieder's research is in scalable information processing. His research began in information retrieval. I recall him telling me a story about how in the mid-1990s, when he was doing his research, he thought that search engine research was dead, and it was going to be just one of those things that just slipped away. And then Google came. And once Google was here, research in search engines boomed, and I think that was he was there at the time, and it was a perfect time. I think it's very similar in some sense to deep learning research today. It's just a hot area to be in, right? So given that Professor Frieder is also in the Department of Biostats, Bioinformatics, and Biomathematics, it's not a surprise that his focus on scalable information processing systems emphasizes health informatics. He has written 4 books, including a classic information retrieval book, 75 journal articles, approximately 150 peer-reviewed conference publications, of course, many magazine and other popular press articles. He's been awarded over $10 million to support his research, including close to $3 million in the last 5 years. He has won 3 Best Paper Awards and is a fellow in AAAS, ACM, IEEE, NAI, and others, and is an inaugural member of the ACM SIGIR Academy. And if that wasn't enough, he's also an inventor who has submitted 125 patents and is an inductee in the Florida Inventors Hall of Fame. And again, in his spare time, when he has a moment or two, he's also the Chief Scientific Officer at Invariant, Inc. I am delighted that Professor Frieder will give our spotlight lecture today entitled Digitized Health. Please join me in welcoming.
Thanks for the intro. I'm going to do something today something I haven't done in about over 2.5 decades. Usually I give these talks. The smallest one I've given is about 70 to 150 people. And therefore, there's no way I'm doing anything interactive. But since the audience is probably about 40 people, give or take, 30-some people, give or take, I'll take questions anytime you guys want, which is something I never do. So if there's a question, just interrupt me. All right. So as Lisa said, I work now in digitized health. Some of the introduction was close. Some was a little off, but it's okay. Today's talk is, as Lisa said, on digitized health. Assuming I can get this to work. Assuming I can get this to work. Okay. So the one thing that's true is there's a bunch of things I'm going to tell you, and you're going to have to either believe me or not. But we'll start with this first thing that's obvious. Change is natural. Usually I have a thing in front of me, but I'll look at it this way. Change is natural. And since we're here, this is what this place was about several weeks ago. It's not a true picture of mine, but it is. And since for those of you who don't know, we just transitioned into spring, so change is natural. And this is what you're hoped to see in about a week or two in downtown. So that's a change of season. So that's natural. Change sometimes is by intent. Actually, you don't control it in nature, but you do by design. So, for example, for those of you who don't know in history, ancient history, this is what we used to be. This department was a bachelor's only department until about 2007. And actually, I came in 2007, so you're a little off. And that was the first course that was taught. The first CS graduate course that was taught was in 2007 in the fall. Anybody care to guess what it was? It was information retrieval, but the truth of the matter, it was a very easy course to teach because I just stole Nosley's, I copied Nosley's course from IIT. She was given it a grant just to show you how things have changed. In the early 2000 era, information retrieval was only taught in very few schools. It was taught only as a graduate level course. And there was no transition to senior level courses at all. She got a grant from NSF and developed this course on information retrieval. So she had the projects and the slides. And since you know that I believe in reuse, particularly means other people's work, therefore I just took her course verbatim, literally. And that's what she wrote about it. But anyway, that's the course I taught. So that's the first course. But it continued. Assume I can get this to continue to switch, yes. In 2011, so this is changed by design, we opened our PhD program in this place. Now, some change can be viewed positive or negative. It can be subjective. For example, there are teaching-oriented faculty only that may or may not like what we did. But then there are those in the lab that basically were academically focused, and this clicker is not doing very well. And I guarantee you that these people, with their position, are quite thinking the positive. It's very positively sentiment. Andrew's at Johns Hopkins, Armand's at faculty at Yale, Sean's at faculty at Glasgow, Eugene's at Johns Hopkins, and Niren's now actually doing a postdoc at NYU. And I guarantee you that they think the sentiment is positive, and he's about to defend on April 29th. So I guess Rishikesh hopes to actually do get a PhD out of here. And of course, some changes, not so subjective. We are now in March. What's March known for? Oh, seriously, what is March known for? And Nehru's already talked about. This is one view that I can guarantee you that was very positive sentiment. In 1984, Georgetown won the NCAAs. That was a positive sentiment. On the other hand, changed in 2023, Georgetown set the record for the worst sequence in the NCAA in the Big East. But anyway, those are all change. Change is transformative, and this is why I'm actually going to talk to you about. For those of you that basically don't know, there was something you called the Icemen. Do you guys know what an Iceman is? And not, unfortunately, the ice of today. What are Icemen? They're gone. That's refrigeration. That's change. How about switchboard operators? Okay, Jamie, you know all of these. It appears that it used to plug into those switchboards. They're gone by switching systems. Assembly line workers were replaced by robotics. Film developers were replaced by digital films. Software developers, you guys are all majoring in computer science, they're going to be replaced by prompt engineers. And for those of you who think you're comfortable with being prompt engineers, you're going to be replaced by generative AI. So that's all going to go. So why am I telling you all this? Because the only thing that's constant is that only thing that life is constant is its change. And the matter of fact, my corollary, if you don't embrace the change, you're going to be left behind. So I'm going to tell you about embracing change. And embracing change today, first and foremost, is AI. Now, AI is a controversial topic. There are those that will tell you that AI is a godsend, it's a blessing. 4 ways AI is helping humans make informed decisions. That was in 23, from the World Economic Forum. From robots to dogs, magnetic slime, 9 ways robots are helping humans. How the share of the good in AI is going to be great. That was about 3 months ago. That was in the World Economic Forum. But at the same time, you're going to find that there's going to be people who claim, you want me to stop moving, I take it. There's going to claim that AI is going to be the worst thing in the world. 14 ways AI could become a detriment to society. Can democracy survive disruptive AI? And of course, this is going to become more and more of an issue, but in January, 200,000 jobs are going to be replaced in Wall Street by AI. So you have to take your bets, and sometimes you just don't want to do that. So there's going to be those that are going to say that it's great, or maybe not. And these are all little clips. But there's one thing that you actually do know, and that is that 40% of the jobs today are going to be affected by AI. That's not my suggestion. That's not my view. That's the IMF chief view of a year ago. And in fact, in economies which are booming, you're going to have much more impact by AI because they can afford it. In the companies that are not, maybe a little less. So why am I giving you all this preamble? And that is because in the United States and in the rest of the world, staffing in medical systems is a disaster. There are 3 different sections of medical staffing in the entire US. The first is called the medical call centers. These are the people that answers your questions. These are the people that basically schedule your appointments. These are the people that remind you and tell you the doctor's not going to be there. There's about 1.1 million of them right now, and 77% of the latest survey find out that they're stressed out, and they last less than 2 years in the profession. They are the nurses. In 2024, there were about 3 million nurses. There are now about 3.5 million. It's a little low. And we are short by about 400,000 nurses today in the US alone. So if you go and you get through the system and you finally get to see the doctor and the nurse tries to start talking to you, you're already short 400,000 of them. But don't worry, you won't get to the doctors either. Because the doctors are basically 100 million people in this country cannot get to a primary care physician when they want to get to it. And I'm not talking about insurance and health insurance, any of that. Just they're not available. These are statistics in the country. And by 2025 now, we're short 64,000 physicians right now as we speak. So I'm not going to talk about getting rid of people. I'm not going to talk about AI stealing people's jobs. I'm not going to lay off 300,000 or 200,000. I'm going to fix the problem where we're really short. And that's right now in the medical profession. So the World Health Organization claims about 4.3 million people are short right now. And in Europe, the situation is even worse. Europe, which is viewed as having a nationalized healthcare system, basically, most of the people are low pay, cannot afford, and aren't surviving. That's in the latest notion. And in fact, it's so bad that the European Parliament just made a statement in September of last year that says shortage of healthcare and social care workers in Europe need to bolster the national healthcare. Now, I'm going to test your eyesight, so I blew it up. According to the World Health Organization, Europe has an estimated shortfall of around 1.6 million people in the healthcare profession. And by 2030, they'll be short 4 million, period. That is, at which point 600,000 doctors short, 2.3 million short nurses, and 1.1 in social staff. It ended with their statement by the European Parliament saying Europe can delay action no longer. So it's not our problem. It's everybody's problem. So what am I going to do about it? I'm going to try to use AI to fix it. So I'm going to talk about several projects. I'm going to talk about how to get you engaged, the patient, how to get monitoring to keep you alive so you don't do something foolish, how you can triage the system so that you can get to the doctor when you really need it, and how can you actually have the doctor give you the medication you actually should be taking. So let's start with that. And you don't want to hear from me. So let me tell you about what you do want to hear from.
and we'll figure it out together, okay?
This is an interface that interacts as a chat conversation in the call center. We'll get to that in a second. But this is the way you get patient information collected. But you might not have understood that. Let me try something else, if I can get this to work.
Salut Jess, je suis Nara. Je suis là pour vous aider.
Speak French? They do in Canada.
Jess, ich bin Nara. Ich bin hier,
Deutsch?
Ich werde Sie niemals verurteilen.
Or 100 other languages that Inara speaks. Inara is available 24 hours a day, 7 days a week, 365 days a year. Never fights with anybody, never has a bad day, never gets sick, and never misses the cup of coffee that in order to keep them awake. In any language you want to communicate with. But people have a tough time talking to Inara, so Inara has to make you feel a little better. There's no such person as Inara, obviously.
Always looking out for you. If I learn something new, I will let you know, and I can explain why it's important.
People are intimidated by the doctors. You get to see the doctor for 10 seconds. The doctor wears a white coat, and and the doctor has 0 patience for you. Inara is available, and they will happily talk to you. But the problem is you won't get to Inara right away. First of all, you have to deal with the call centers. And as I just told you, they last less than 2 years, and they're short 1.1 million today, and the number is getting longer. And they only speak one language. But let's see what other people do. And this is a system that's deployed someplace. I won't tell you exactly where, but you'll probably figure it out.
Welcome to the Janssen Men's Call Center. My name is Inara. How can I help you? Hi. How often am I supposed to...
This is not scripted.
Trachlear. Patients prescribed Trachlear need to have a liver test before receiving the first prescription and every month while on the treatment. Thank you. When do I need to get my next liver test? To answer that, I need to confirm your program registration. What is your name and either the email or phone number you used to create your Janssen RIMS account? Yeah, my name is Jess, and my phone number is 470-999-1212. Thank you, Jess. I have texted you a code. When it arrives, please either read it to me or text back the word confirm. The code is 471936. Thanks. I have confirmed your registration. It looks like your last liver test was June 15th, 2023. To continue Trachlear, you will need a liver test done no later than July 17th, 2023. Would you like me to order that test for you? No, thanks. I can do that later. Okay. Can I help you with anything else? No, that's it.
So this was an interaction. This is an interaction that's developed right now and is actually running as we speak in a situation where you basically have to have interaction and it has to access your medical records. Now, the problem is, by law, you need to log all your questions, so it automatically logs it, and therefore you records it. But unfortunately, none of us know how to read or to actually bother to read anymore. So we basically decided that we better have a shortened version of it along the way, so it gives you a shortened summary of it that's automated. And of course, you need to know whether you liked it or not, so it gives you the sentiment. This is the way you interact with a call center right now in any language you want, because as I showed you, Inara speaks over 100 languages. So anyway, this is developed by Invariant jointly. So now that we actually got you an appointment, told you when you needed to have an appointment, made sure your medical records are available to the doctor when you need it, and got you scheduled, we don't want to get you there unless you have to be there. And the problem is that right now, behavioral monitoring is a big problem. The big problem is when you transition from one form of your life to another, say like from active service to the VA or the like, you have a problem because people lose hold. They basically get depressed, and depression is a big, huge problem in this country, leading to a large amount of suicide. And usually what happens is if you are actually informed that you are depressed or waking up or keep you going, you can prevent self-harm. So we call this the guardian angel. The approach is to monitor what you're doing, learn your normal behavior without intrusion, without sharing your data, and be able to tell you that, hey, listen, something is wrong, and notifying the people that you want notified along the way. So the question is, can you monitor people's social media to do this? Well, social media works, but only to a very limited extent, if I can actually get my clicker to work. Because although you interact with social media very often, and you almost never interact with your doctor, the red is the number of times you interact with the doctor, the blue line is the number of times you interact with the social media over a period of time. The reality is that's not going to help you very much, because if you actually look at when you actually have attempted suicide, various patients, that's the green line, there's some patterns, but there's really not a conclusive pattern, because you can see sometimes there's gaps, sometimes there's not. The question is, can we really see a little better by actually checking what you are all about? This clicker is not being very helpful. So we're going to learn what you do. On an app, we're going to make sure that we learn how you're functioning, and if you're deviating from functioning, maybe there's an issue. So this is you. You're sleeping, you're eating, you're doing, et cetera, et cetera. For example, during the week, you basically, or during a month, you basically ate a certain number of times, you slept a certain number of durations, you basically walked a certain number of times, you basically did for this period of time during a certain period of time, you basically worked it, or you were at home at a certain amount of time, and you were basically in a certain location a certain amount of time, and in fact, you were interacting with these people for a certain amount of time. Mind you, it's learning all this without you giving it any feedback, without you doing anything. It's just learning it from the patterns that it's seeing and observing by location, by interactions, and so on and so forth. And that's great. That's you on a normal basis. And then one day, you're doing none of that. You're sitting around the house. You're not eating anything. You're not going anywhere. You're not communicating with anybody. Just kind of sitting there. Now, it could be that your best friend just showed up, and you decided for 1 week, I'm not going to do anything but sit with my friend, go have a good time, watch TV, and do nothing. That's okay. Could be that you broke your leg, and you can't walk. Not good, but okay. Or it could be that you are the #1 sign of depression. Your mood and life has changed. In which case, if we get this to work, which we're not, in which case, we've already had a self-guide that you have entered the information to that says if I'm really mildly different, and I think it's a depression, I'm going to notify Nancy Green. If it's more like a medium level depression. But if it's just low, I'm going to tell, hey, listen, why are you doing this? Just prompt yourself. And so on and so forth. And when we do tell these people, we're going to send them the report of what you normally do. And what you normally do is going to tell that you've deviated from it. And by deviation from it, there's going to be action taken. And the doctor's going to know about it, and the healthcare is going to know about it, and everybody's going to know about it, that you have permitted to know about it. And the reason you care is because screening today does a bad job. We're short of people. It's hard to get an appointment. There's no information obtained. Screening accordingly, to quantify, is 1 out of every 25 people that needs to be seen gets seen. According to this system, no longer quantified now, it's undermined, bought about things. At least when it was inactive, about 11 to 25 are found. And the reason, how many of you read trashy books? See, I can do this because it's a small group. How many of you read trashy books like I do? Oh, yes, you do. Okay, at least some of you are honest. Okay, I went the wrong way. Hold on. How many early detection saves lives? But more importantly, not more important, less importantly, how many know that saying? I already gave you a hint. It's a trashy book. How many of you read Michael Connelly? He's a great author. I'm being videotaped. This is from the Harry Bosch series. Everybody counts or nobody counts. So anyway, that was done by a bunch of people along the way. And now Glenn's actually at our page. All right. Most of the stuff is patented. It's not, there's very few publications because companies actually care about getting it done to market and actually saved. So we'll forget that for now. Triage. So that part keeps you away from the medical profession unless you have to, and identify who needs to be in the medical profession to save against self-harm. Get you to the right appointment in the right time, in the right thing, in the right language at any time you want. Now, that was for the call center in the early part. What about the nursing? How many of you remember this terrible thing or this small inconvenience called COVID? Remember that? And we were very well prepared, or actually we weren't at all. We couldn't test people to tell them what is wrong with them. Do you have COVID? Do we know if you have COVID? We didn't have test kits. We couldn't get anything done. So people were going to get tested. And where were they going to get tested? To the infection center. They called it the testing center, but really it was the infection center. You had super long lines where the nurses were scrubbing it, so they were getting infected. And most of the people didn't have COVID, but they went in these long lines anyway and met the people who had COVID so they could get infected. And the lines were super long, so the ones who should get tested weren't. So the question is, can we do a way to solve the problem that there were no test kits? Now, I'll tell you when this was done in a second. So, dawn of tomorrow, automated triage. The real question is, are you sick? Are you critical? Or you're just tired and fatigued? That was the question. Don't bother getting tested absolutely immediately, and then I have no idea. You got something, but we can't tell you what. So the issue is how to do this. We didn't know. What we did know is that if you had COVID or any other disease, you had fever, cough, fatigue, shortness of breath, loss of sense of smell. That's what we know. We also knew that you could be able to tell us, are you normal? Or we could be able to tell if you're normal. Are you a little different? Are you significantly different? And we could say, if we are okay, we get a 1. If you're not okay, we get a 2. If you're really bad, you get a 3. And we knew that COVID didn't affect people in the same way. No bias statement intended, but COVID affected age differently. COVID affected gender differently. COVID affected ethnic background differently. COVID affected comorbidities differently. COVID affected everybody differently. There were population groups, but it affected each group differently. So there was an issue of, can you find what is the personalized likelihood of threat that would affect you more or less? And if it is going to affect you more, then we wanted to maybe warning you more. If you're going to be okay and you're just going to be inconvenient, we can raise the threshold. So let me ask you a simple question. How many of you actually think of phones for talking? You're going to be a gender gap here. The guy in back in chemistry, you probably use your phone to talk, right? You take pictures. Okay, so you're one of these people that does. Generally speaking, you use it to talk? Yes, you're the wrong generation. Watch. How many of you actually use your phone to talk? A few of you. Some of you. How many of you use it for texting? How many actually use it really for health diagnostics for all your apps? All of you do. I close my Ring to make sure I walk enough. Oh yeah, all of a sudden hands go up. In COVID era, it became the device for contact tracing. We thought, you guys are missing the opportunity. It really should go for corona testing. And it should do it via what's called surrogates. Surrogates, what are surrogates? Well, we can monitor all these illnesses, all these symptoms by other things. So, for example, fever could be measured by the phone. If you either do it either by a gun, if you had a temperature, electronic temperature gun, or just by heart rate variation. If you've got a fever, your heart rate varies more, higher, faster. So if you're normal, we gave you a 1. If you're a little impaired, we gave you a 2. If you're more impaired, we gave you a 3. If you were coughing by sound wave, if you were okay, we gave you a 1. If you're coughing heavily, we gave you a 2. If you were basically fatigued, how do we know if fatigued? Well, did you close your ring, i.e. your activity ranking? You're not fatigued. Or were you always sleeping? If you're no fatigue, we gave you a 1. If you're more fatigued, a 2. If you're significantly, a 3. If you were basically shortness of breath, it's easily to detect by sound. Same story. If you basically lost your sense of smell or taste, how do you know if you lost your sense of smell or taste with an iPhone? How many of you eat onions? How many of you know that those onions actually are sharp? And how many of you know that if you smell garlic that you have at home or an onion, it's got a smell? I can't. I have like 0 sense of smell, so I'm excused from this, but everybody else would. So get instructions. Go get tested. What did you do? And when we got all that information, we basically summed it up by the propensity of how likely that's to indicate COVID. How do we know that? Because people were reporting 86% of the cases had COVID, that had COVID had fever, 67 had cough, 42 had fatigue, shortness, labored breathing, so on and so forth. And what were those values? 1, 0, 1, and 2 were those fever, cough, fatigue, and so on that you scored. And we weighted it by the percentage of those to indicate COVID. And if you sum total and you were under 2.8 for this being the typical normal person, no problem. You're okay. You must be just tired. If you're over 4.0, get tested immediately. You're probably in serious risk of COVID. And in between, don't know. But this would reduce dramatically the number of people that needed to go get tested. Now, by the time we put this onto the market, which it was licensed, actually from the school, it was already changed. It wasn't no longer that's the symptoms we knew. This were the symptoms we knew. And as the time went by, mind you, this is April of 2020. COVID in this country came in March. It came in March because we canceled March Madness, so it definitely came in March. By 2020 April, all these have been different functions, and it's okay. How do we fix them? We just put them in, we just plug in different weights, and it worked. And by the time this got deployed, don't worry about it, more came out. And by the time that shifted, more came out. And so on and so forth. And this was developed, and here, we had a patent issue in January 21. We developed this in March of 2020. By April of 2020, this was operational. It was licensed from the school to a French international company, and was done. So these are the 3 patents that were tied on it. Again, company said, we're done, you're not writing about it, so we didn't. So that's where that's. So that basically got you only to the case where you needed to go to be tested if you're likely to have had COVID. Now you're finally the doctor. You've basically went through the call center and you got through, and they talked to you in your language at any time of the day and everything else. They collected all your information from you because it was a nice friendly chat box that you interacted with. It was all friendly. You basically know that you needed to be there. You were gone through and then testing, you got tested. Now the doctor has to prescribe you something. So what's the doctor going to prescribe you? How many of you think how many of you think medicine is science? called the art of practicing medicine. You ask a doctor, they will tell you that it's the art of practicing medicine. And that is what they do. So how do they practice medicine? How many of you think you're unique? I like this small group. It's the first time I can actually ask questions and have people answer. How many of you think it's unique? You're unique. God, you guys have got a big ego. Your fingerprint is unique, but you're not unique. If there's 1 million cases, or 10 million cases, or in this case, 4 million cases, there's going to be someone who's going to be like you medically. And there are people like you medically. They are called your digital twins. And what happens is the doctor comes and tells you, you've got this illness. And the question is, can you find out which medication will work for you? Because your personal background affects what kind of medication it is for you. And if you think there's guidelines that can help you, you're being very optimistic. In this country, 2/3 of the women between the age of 16 and 65 suffer from what? UTIs. Like it or not. And about 1/3 of the women in this country between that age have got what's called recurrent UTIs, 2 or more episodes within 6 months. So how do we fix it? We give them lots of antibiotics, and you know what happens? We get resistance, and it doesn't work. So how do you give the right prescription to the right person so you don't cause that? Well, the way we do this is we find your digital twin. The doctor says you have this illness, and we looked at your digital twin and see what that would suffer the same disease that you have and find out what medication worked on that digital twin. And we need one more thing. We need to make sure that you can explain it. Because no doctor is going to prescribe you anything that that doctor can't explain. So how do we do this? We take these large collection of documents, of medical records. It's about 4 million of them. We took it from the National Health Insurance Database of Taiwan. We map them all into graphs. The graphs represent, and of course this was an IRB, of course, yes, we know. We'd use the same criteria doctors use. How do you know, how do doctors assume that it works? Well, if you got a medication, and if the medication got rid of your symptoms, you're cured. If you didn't have it for the next certain period of time, that's considered a success. If you do have that same ailment in a short period of time, that's a failure. That's the way the medical doctors define it. Okay, I'm going the wrong way. So we map all these into graphs. This is a graph. Male, 71, et cetera, suffering from bacterial pneumonia, was prescribed ciprofloxacin. If it works, was prescribed ciprofloxacin. And then after 90 days, there's nothing, no symptoms, nothing. So that's a success. Here's a female, 67. She was also suffering from bacterial pneumonia. She was prescribed all these medications, but unfortunately, 3 days later, she still has all the symptoms of the same disease. So we added erythromycin, a different antibiotics, and now she's fine. So that part is considered a success, except it didn't come back. I moved it too quickly. Doesn't matter. It's a success. So graph kernels have got different properties that you can match graphs. And they can be for various different things. They can be basically for the most common medical ailments you have, the correlation, the sequence between them, et cetera, et cetera. It doesn't matter. You can create a whole bunch of graph techniques, which don't look at me. I didn't create them all. But they all are patient graphs to match against your digital twins. So you could do a whole bunch of them. You can compare against. And you can take a whole bunch of medical records, and you can try on a variety of diseases, and you can predict which ones work, and you can get a decent efficacy. Enough efficacy that you say, wow, it worked on short diseases, like when you give antibiotics, can you do it on long-term chronic diseases? And you just change the metric, because the doctors use different metrics, and you can do the exact same thing, and lo and behold, it'll work that too. Now, these numbers I don't care for you to watch. Suffice to say is these different metrics and different things basically have been able to create better efficacy than the standard doctor can. So that was a nice write-up, and we wrote a bunch of papers on it. How many of you are PhD students? Okay, you guys care about those papers. I'm an old tenured professor. I don't care anymore. I'm not sure I cared from the beginning, but certainly don't care anymore. I care about actually making it useful. So the first thing you need to do to make it useful is being able to interpret it. Yes, you don't want to make it useful? Oh, you're on tenured. You do care. There's a certain benchmark comparison of how the treatment of how long success it was versus other approaches of successes. It's using patient records to progress. It's a retrospective study because, trust me, you're not going to get medical doctors to use something that's totally not usable for them. And this wasn't usable for them. We'll get to that in a second. And how do you make it usable? You need to make them actually understand why you prescribe yes or no. So here are ways of comparing 3 different metrics to decide for this patient, this kind of thing, who is the closest patient, and did that prescription succeed for them or not? And if the majority are failure, then you say no. If the majority are then you say yes. Now we can explain why we said it's going to succeed or fail. But again, the doctors couldn't care less. They didn't care less until they can actually play with it. And with all due pardon to PhD students and faculty even more, we build bubblegum type software. It works for 1 day as long as you only ask it 1 question, and you don't have to maintain it for that 1 day either. Doctors aren't going to rely on that. You see the PhD students in back going, no, we build very safe software, sure. Except they actually build real software, these guys. And he saw this, and why did he see? He saw a statement, and he got excited. He licensed it from the school, the technology, because it was an explainable AI-driven prescription prediction technology that productized scalable, patient-specific prescription selectors, reducing drug resistance, thereby improving patient care. This is the press announcement that was done in like 20 different languages all over the globe. I just picked one for a while, and some of my earlier talks I produced like in 20 different languages. Then one guy said that there was a typo on it, so I dropped him. But anyway, they licensed it. By the way, how many of you heard of Exceller? You didn't. How many of you hear of Grok? You know what Grok is? It does these small little things. You kind of run them on the computer, kind of make things go fast. Yeah, Exceller's a Grok company. They make high-end GPUs. So they license technology, and because it implies the doctor can understand. And this is they built patient graphs. So this is the pictorial representation of a patient graph that they used for hypertension and so on and so forth. This was an example of a hypertension case which didn't do so well because they had a heart attack. That's not a very good example. This one did a little better, so it was success because they didn't have a heart attack. This is what their interface looks like. It basically lists what kind of diseases you're looking at, the doctors, who are the patients that the doctor has, what are some of the information about the patient. And the doctor basically says, I think your diagnostic is those, picks from a slate of diagnostics, and I'm going to give a prescription. I'm going to pick a certain prescription, and I'm going to press a button, predict, and it's going to tell me, oops, no good, didn't work. Don't worry. I'll look at those patient graphs, I'll press them, and it'll tell me what the features are. And in fact, I'm going to ask him, who are the most similar patients that it didn't like? Who's the most similar one? Based on this criteria. Well, based on different criteria, you will see different matching criteria. So here's the one with most common medical events. Here's the one which is the most sequential events. Here's the one that has something else. The bottom line is, given a patient, given a diagnosis, given a set of treatment options, I want the one that's going to be best succeeding for me. So it's going to predict that for you. So that was what was done. And these are the people that played along with it. And since we actually started within academic things, it's actually our publications. But obviously, it's licensed and the university patented them all because it translates for various reasons. We'll leave it at that. Now, I don't believe in painting a rosy picture. I told you a gloomy situation about how people view AI, positive and negative, and those that hedge their bets. I told you it's going to affect the job. I assure you they may get rid of some. I assure you that we're such a shortage of people that this is not going to get rid of it, it's just going to help the situation. But I'm not an optimist. I'm a realist. So let me tell you a little bit of uncertainty and cloud. In 2020, Microsoft patented a bot, a virtual, beautiful, successful type-oriented bot that basically acted like you. You took the readings, the writings, the speeches, the images of this individual that you wanted to model, and it did it. It created a virtual person that you could talk to. And that was great, right? Wouldn't you love to be able to learn physics from Einstein? Dear relative, you learn it from Einstein. You want to learn about history? Learn it from somebody. You want to meet your great-grandfather? No problem. Here's some writings. Go meet and interact with them. That sounds great. But today era, it's not so great. Because whenever I can give you a positive, the same that I showed you about AI, the blessing, I showed about the devil incarnate. Positive interactions, I can find you negative ones. For example, in today's era of hate, who would a racist model? What kind of bot would a racist make that you can disseminate across the whole network? How should you govern against it? What kind of rules apply? Who should do it? I don't know. I have no idea. But I can tell you that it's unclear, but I tell you the urgency is great, especially nowadays. So let me end with a couple of things. One is AI is not a panacea. It can help, but it cannot replace. You should never have AI try to replace the medical profession, because at the end of the day, the clicker doesn't work. At the end of the day, AI is not human. It's just some software that somebody built. Patients deserve more than just some arbitrary software that basically does things and tells you in some way what to do. AI can reduce shortages because there are a lot of things that you don't have the people, that AI may not be the ideal solution, but AI will help. And it can be there 24 hours a day to monitor you, to guide you, to help you, and can inform decisions. AI is not a substitute, but it can be a tool. So with limited resources that you've got, the limited call centers, the limited nurses, the limited doctors, this can provide a better informational infrastructure. It'll make it a better informed caregiver. And with all due pardons, second opinion never hurts. The doctor doesn't have to take that opinion. The doctor can say, I know better. The doctor can have ideas that aren't there from off-label users for things that they learned from before. But a second opinion can never hurt. So there's a lot of people I'm not listing. And these are a lot of people who I am listing. These are basically the collaborators of the people who've done all this stuff. I'm sure I'm missing a lot, and I know I'm missing a lot of clinical people that basically gave us the medical feedback and deployed some of these for the early testing to test, and the various company owners and so on and so forth that sponsored and so on and so forth. But it doesn't matter. But let me, I always end same way. Been doing this for eternity. As I said, usually it's a huge section, so, but I end the same way. I end with 3 peeves, always, everything I talk. Number 1, you always, always, always finish on time. Why do you finish on time? Now, I know there's faculty basically rant and rave, and I do. And if I have to kill time, I can do it very well. But you always finish on time because people are an audience. And they came and allocated that time for you. Not more, that time. So you should always, always, always finish on time, and I always do. That's 1. Second peeve. You should always leave time for questions. Why? Because if I didn't leave time for questions, you would think, that guy memorized it all. He doesn't have a clue what he's talking about. And he has no idea what these things do. But he memorized a script, and now he's regurgitating it. And he's done this often enough, so it's going to be okay. So you always have to leave time for questions, because otherwise they're thinking that you don't know what the questions, you're afraid of questions, you're not going to give time for questions. So that's peeve number 2. But peeve number 3 is the absolute most important of them all. Peeve number 3 is never leave much time for questions. Because if you do leave much time for questions, they know you scripted it, and they know you memorized it, and they know you don't know what you're talking about, because they'll ask you the questions you cannot answer. So I was told that I was to speak and to leave room for questions, and that I was to end at 4:30. It is now 4:28. I've got room for 2 minutes worth of questions. Are there any questions?
Thank you for that, and I want to make sure we get time for a few questions. Lucky for me, I told him 4:30, but I meant 4:35, so we got a couple extra. Do you have a question or 2?
Yeah, go ahead. Sure. Well, he's speaking to a mic, but okay, I'll repeat it anyway. Go ahead.
Since there is a shortage in many countries for physicians.
All countries, almost.
All countries.
Almost.
Might be an open source AI model that will be optimized by many countries at the same time. So it will develop quickly. Now, it will be used in case of shortage, maybe they'll depend on the AI alone. If at a certain point it proves to be better than the human physicians, what do you think the scenario?
The question is, will there be an open source AI system that will support medical diagnostics? And would it be better than the doctor? Is that a fair summary of it? Well, there are open source medical stuff today. The problem is the question of whether you actually want to trust it. Today in AI, we reinvented terminology. See, in the past, when something got wrong, when we got the answer wrong, we said it's wrong. When we did a computation and the math came out wrong, we said it's an error. We thought that wrong information was wrong. Today, we are much better than that. Today, we're not getting it wrong, we're hallucinating. Sounds much better. We don't get it wrong, we're not lying, we're not plagiarizing, we're hallucinating. And if you're going to use AI that's unsupervised, currently, it's not an option. And quite honestly, I wouldn't trust Dr. Google. You Google anything, if you have a runny nose, Dr. Google will tell you that you now have a brain tumor. If you've got a bleeding nose, for sure you got a brain tumor. By the way, if you've got indigestion, oh my God, you basically have got cancer in the stomach, or a heart attack, or any of these things. Because that's what they're going to talk to you about. So there is a future. There are some open source. We are actually trying it. We collaborated across the globe, but not going to be a replacement. Not anytime soon. You can't ask me questions. Go ahead, Jamie.
So one, thank you for your presentation. Use of AI, and the various ways that people use AI. How would the general public know, or people who are not deeply familiar with the technology and rely and use it, know what's a good one, what's a bad one? What are the metrics that allows us to evaluate whether I'm using a good one or a bad one? What, and I'd like to hear your thoughts on that.
All right, so the question was, there's so much out there. How do you know what's good? How do you know what's bad? The answer, unfortunately, is you don't. You need, the same way as you don't, how do you know if the source of information on a web search is correct? There are organizations that kind of label it and, quote, do testing for you and announce it. This is a trusted site. This is a trusted app. This is coming from a trusted authoritative source. So downloading it from I'mSellingPopcorn.com, a medical app, may not be as good as downloading it from the CDC or NIH or any of these other places. That said, information also changes. And the problem is science and information changes. And you need to keep on doing more science. And unfortunately, we're having less and less of it done. But that's the reality of it. So I'd love to give you an optimistic answer. But unless there's some trusted organizations that basically are going to do benchmarking, and there's very few of them that are, you're not going to know. That said, never, ever, ever rely purely on these things. Everything I've talked about is a thresholding thing that tells you go do something, go find out. The medical profession was an advice for the doctor. The triage was a selection of self-testing. And monitoring the same thing, and of course the communications on its own. It's 4:32.
One more, and then we have a wonderful cocktail session that we can talk more about.
Oh, wait a minute. Paul, he's not even from computer science.
Curious about diagnoses for asymptomatic people, where you were mentioning, I think, diagnosis for symptomatic people using different criteria. There's so many diagnoses, particularly in cancer, are made for people that show no symptoms yet. So what are your thoughts on how we build AI devices for those diagnoses?
All right, so I didn't plant that question, because right now we're working on a cancer screening. And what we're doing is we're developing an approach for cancer screening based on your medical records. It turns out that it's not, I don't want to say not hard, it's not impossible to predict the likelihood of cancer 6 months out, pre-symptomatic appearance. You're not quite as good for a year out, and we are actually better than almost every attempt for 5 years out. But it's not there yet. The goal is not to have it as a screening. The goal is to have you, again, put priorities ahead of the line. So the same as I said with the testing for COVID, we didn't say this is detecting whether you have COVID. This is detecting the urgency by which you should have COVID, or you're likely to have COVID, not should, likely to have COVID. If you talk about cancer screening, the way you can detect cancers ahead of time is by scans, CT scans, ultrasound, and blood work. The problem is people don't do that. So the question is, can you get people to go through their medical records? Can it do it systematically to say, hey, listen, you are really a candidate, somebody should be doing it. And that's what we're working on right now. Has it succeeded? Well, I'm not buying Georgetown yet, so I guess not. We're starting to. We're trying to. Thanks.